Welcome to the Healing Pain Podcast with Dr. Joe Tatta. Each week, we interview top experts in physical therapy, pain science, and integrative pain care. You'll learn the most up-to-date information for treating and reversing persistent pain. This podcast is for educational purposes only and not intended to be used as personalized medical advice. And now, here's your host, Dr. Joe Tatta.
Hey friends, welcome to this week's episode of the Healing Pain Podcast. I am your host, Dr. Joe Tatta. As always, it's a pleasure to be spending this time with you. This week, we're discussing an important reimbursement issue related to physical therapy as well as pain care in general, and that is value-based healthcare. Value-based healthcare is a healthcare delivery model in which providers, including hospitals as well as practitioners, are paid based on the patient's health outcome. This model differs from the traditional fee-for-service or capitated approach in which providers were typically paid based on the amount of services they delivered. Joining me this week to discuss the trend of value-based healthcare, specifically in the physical therapy profession, is Dr. Alice Bell. Dr. Bell earned her Doctorate of Physical Therapy degree from the University of Montana, and today is on staff as a senior payment specialist in the Public Affairs Unit of the American Physical Therapy Association. Her professional activities include serving as a member of the Centers for Medicare Technical Expert Panel for Alternative Payment Systems, the CPT Editorial Panel, and is an APTA appointee to the NDHI Opioid Crisis Work Group. Dr. Bell has been involved in bundled payment projects and exploring alternative practice and payment model efforts focused on the early and direct access to physical therapy. On today's episode, you'll learn all about values-based healthcare, where values-based care intersects with the biopsychosocial approach to pain, how physical therapists can assess their readiness for participating in an alternative payment model, and how physical therapists can play a more central role in addressing pain in the U.S. healthcare system. Okay, without further ado, let's begin and let's learn about values-based healthcare with Dr. Alice Bell. Hi there, Alice. Thanks for joining me this week.
Hi, Joe. It's great to be here.
I'm excited to talk to you about this topic on the pursuit of value-based care. I have been very interested in this topic for a couple of years, and I've been watching it grow. And when I talk to my colleagues, some are very interested as well, and some haven't really quite heard about it yet. So I think this is a really important episode, especially as we move forward, looking at pain and lifestyle and all the things that we're concerned about, and we can be effective with regard to PT practice. Let's start here. People hearing about values-based care, what is really meant by value in healthcare? The word value oftentimes is thrown around. What does it mean in the context of this conversation?
It's really interesting, Joe, and I think it's an important question and something we really need to think about. So we hear the traditional kind of definition of value equals outcomes over cost, and that's what we hear over and over again. But when you start to break that down and really drill down to that, the reality is that value is really both stakeholder dependent and it's relative. So when we talk about outcomes specifically, what is important to the person with whom you're interacting? And that's different. So what's important to the patient versus what's important to the payer or the legislator or the regulator, it's very different. And cost even can be a bit relative and stakeholder dependent in terms of, is it worth it? And that's different for different people in terms of the resources they have. I think the other thing that's important is when we look at relativity, it's not just, does what we do bring value? Is it worth something? But is it worth more than something else? Mm-hmm. So we have to kind of justify in many ways that what we're doing is meaningful to the person who is engaged with us, and that it is equal to or better than something else that they could also get. So I think one of the challenges, because of that stakeholder dependency and relativity, is that we're often having to balance what's meaningful to a number of different stakeholders, and those things are not always symbiotic. They're not always aligned. So we have to think in terms of the context of our audience and that whole concept of relativity.
There's a lot right there just to open up. I mean, just that one answer. So the stakeholder you mentioned, there are multiple different stakeholders sometimes. So the patient's a stakeholder, of course. That should be the priority, but sometimes isn't necessarily always the priority. An employer could be the stakeholder.
Correct.
A private insurance company could be the stakeholder, or a government payer could be the stakeholder. Did I get them?
Correct.
Did I get them all?
You probably did. Yeah, I think sometimes we can even think of legislators as stakeholders, because we're often trying to get legislation passed that will address access to our services. And so that's another stakeholder that, what's important, their constituency. Are they going to make their constituency happy?
Right. Which is important when we think about things like the cap and things like that have been going for since I graduated school in 1997, which is when it started. I remember it very clearly.
Exactly.
And then you mentioned us as professionals have to be able to, in essence, prove that the service, if you will, the product that we're delivering is of value and maybe even more valuable than another service. So for example, and I'm just using this as an example, I'm not saying it is or it isn't, but let's say a patient seeing a PT for chronic pain versus a patient seeing a psychologist for chronic pain. We have to begin to prove that, in our case, PT is more effective or more valuable in that case. Is that right?
Yeah, what's really important is that we have data that allows us to compare what happens with a patient, for instance, a patient who sees a PT first as compared to another provider. Now, sometimes we're comparing one provider against another. Sometimes we're comparing a set of providers against a single provider. So in terms of behavioral health or psychology, those may be much more, that may be a model that is much more appropriate as a collaborative partnership with a PT, particularly to affect chronic pain. And so maybe you want to not so much compare the psychologist to the PT, but you want to compare a psychologist and a PT to someone who sees a surgeon first or a primary care physician first, and what their trajectory or path is. But yes, that issue is really, really important, that we be able to look at not only what happens for patients who see PT, but what happens for patients who see PT versus those who never get to see PT, to see a PT, or those who get to a PT so far downstream in their care that all the opportunity for cost savings was missed. Does that kind of answer your question?
It does. I mean, the thing I think about most, and I've talked about this on the podcast and discussed it with other professionals. I actually have a physician coming on in a couple of hours that I'm going to interview about the VA stepped care model.
Yes.
And really what they started to do, like in that stepped care model, was saying, okay, we have individual providers and then we have a multidisciplinary pain center. When do we implement those things? When is it appropriate? Because if we just send everyone to multidisciplinary care, that can be extremely expensive. And the insurance companies have already sent us a signal that that's not necessarily what the direction that they want to see reimbursement go, if you will. So providing value, as you mentioned, PT alone, or maybe just a PT and a psychologist is part of this.
Sorry, Joe. I was just going to say, I think that's a really important point, because sometimes I think we get caught up in kind of the best model and assume it applies to everybody, right? And the reality is that, first of all, it doesn't apply to everyone. And second, we could never absorb the cost of giving this extravagant model to everyone. And why would we, when it's not aligned with what their needs are? So we have to look at things in relationship to the goals and values of the patient, what's important to them, what are they trying to achieve, and what's the most efficient path to achieving that.
Yeah, I really appreciate that, because so often people say, well, the gold standard for chronic pain is multidisciplinary care. And my clinician mind kicks in, meaning, okay, do we have enough clinicians in the world to provide that care? No, we don't. Right. From a financial perspective, my brain kicks in. Okay, even if we did, that's a very expensive care to deliver. Okay, let's say we found the money. Do people really want to go to either an inpatient or an outpatient multidisciplinary center for 3 months that takes hours out of their week. So all those are factors in
That's right.
providing really effective and efficient care. I think that's the key. It's effective, efficient, and economical. It's like the 3 E's, right?
Exactly. Absolutely.
Yeah.
And then putting that in the context of the individual and what's important to them.
Right. That's right.
And what they're willing to expend in terms of resources, whether it's dollars or energy or time.
How did we arrive here at this place of value-based care where we're talking about this and excited, yet also trying to figure out, okay, what does this look like in the different circles we all function in?
Yeah. Interesting question. So in part, we arrived here because of the unsustainability and the somewhat inferior performance of our fee-for-service model. And so what we know is what we have isn't working. And we know that there's a path to something better, but we're kind of caught in this intersection between where we are and where we want to go. And it's a really difficult transformation. So I think sometimes people think we arrived here just because we're trying to cut cost. We can't afford it anymore. So we've got to just cut dollars. And that's certainly part of it. But there's a whole bunch more. And I like to think about a little bit more about patient and provider flexibility as being one of the big objectives of this, is that we're so constrained by this kind of CPT coding procedure and service environment that there's a lot of things that patients can benefit from that aren't coded. And so all those things that we know can help and that there's some evidence around have to be absorbed by the provider or the patient or someone because they're not paid for through the traditional fee-for-service system. And if they can't be absorbed, they just don't happen. So people don't get what could benefit them or what they need. So part of it is to kind of move to this more flexible environment. We're not so constrained by that fee-for-service definition, and we can start to do what makes sense. What does this person really need? I mean, we see doctors prescribing a healthy food plan for someone and an insurer paying for that in a value-based payment, something that never could or would happen under fee-for-service. So it's really that goal toward, matching the needs of an individual with what, again, going back to what's going to be the most efficient and effective way to help them, get them on better footing, help them pursue a healthier life. It doesn't dismiss the need for the traditional services and procedures that are defined by CPT, but it doesn't constrain us to only that.
So in a value-based system or a value-based model, I know some of these have popped up around things like total joint replacements, for example. Instead of the PT billing Therex and manual therapy and therapeutic activities, so the physician billing whatever they bill, and we bring other providers in, they're all billing things. Is it that there's one lump sum of money and then we're providing care, and there's, in essence, we're not ticking the box off on the CPT codes as much?
So interesting question. So here lies a little bit of the challenge. Bundled payments are like total joint comprehensive care for joint replacement are built on a foundation of fee-for-service. So what was done to create those models is looked at historical claims data, all of the care that was traditionally provided to a patient, how much that care cost, and then there was kind of a discount laid over it because that really was a targeted cost savings program. So the provider, whoever was considered the kind of trigger of the episode, so it's often either the hospital or the surgeon who is triggering the episode, does get a lump sum of money. And then they're supposed to manage the care of that individual, in the case of these bundles, 90 days out. So that includes the surgery and then everything that happens thereafter. The problem is, it was built on a fee-for-service infrastructure. So it's looking at cost based on what we have always done, not kind of what we potentially could be doing. Second, this CPT system is so ingrained in us that even in these models, we're requiring people to still jot down the CPT and track what they did as if that is really telling us everything we need to know. And so I consider those bundles to kind of be this middle uncomfortable spot in the transition from fee for service to value based. It's like a hodgepodge of the old and the new, and we're trying to move, but we're not really getting there. I think ultimately, to get to true value based care, we have to look at population health management. We have to look at really taking a group of individuals and being able to kind of restructure healthcare delivery around those individuals based on understanding the population and what they need, rather than these very kind of targeted procedural areas and relying on old claims data.
So in the example, and yeah, it makes sense. In the example you gave, the physician or the hospital is the trigger.
Yeah.
And that makes sense because obviously a total joint replacement, there's a physician performing the surgery. And then that provider is in charge of managing that sum of money. Is that correct?
That's correct. So
and does that mean, because I think our colleagues are going to wonder this, if, I don't know, whatever, I'm in the town next to the hospital, I have a private practice. If I'm not part of the medical system or the hospital system, can I be part of that value-based care episode?
Yes, you can, but whether you'll be given the opportunity is the question.
Right.
So what ends up happening in those models is that kind of triggering entity decides who their partners are going to be. And so there can be competing incentives, right? There's benefits to an integrated health system, but there's also challenges to controlling the flow of patients in order to control expenditures and cost. And so that's what we see. And the other issue is, if you don't look at quality outcomes and the cost, I mean, someone may dramatically cut costs, do really well, but those patients a year later may be back in the system or 6 months later, back in the system for avoidable issues or problems, or never achieve the quality of life that they might have achieved with a different trajectory of care. So, I think this movement to really integrate both quality metrics and cost metrics is the ultimate end game. It's where we have to get, because it kind of goes back to that. Is it worth it as compared to? Well, you've also got to look at the outcomes as compared to, right? So I spent less, but 6 months later, that patient is in a skilled nursing facility because they fell. Or 6 months later, that patient's not leaving their house because they never really achieved functional community ambulation, whatever it might be. We're not necessarily projecting out far enough, because many of these episodes are 90 days, as I said. And we're also not gathering enough of meaningful quality metrics to really measure the impact of some of these cost saving strategies.
So my mind is turning a little bit as we're talking.
Mhm.
And again, I think our colleagues in the PT world are going to want, and other professions too, not just PT, but they're also going to want to know, are physicians the only one who can trigger this and manage the episode of care, which in essence means manage the money? Can a PT be let's say someone comes to a PT for chronic low back pain, which is a common daily occurrence in the PT world, as well as the chiropractic world. I'm assuming that chronic low back pain is such an expenditure for the healthcare system that eventually someone's going to start to look at that if they haven't already. And can we be the trigger for that value-based episode of care? And can we manage it? Because we, based on where we're heading in this country, at least, and I do believe that globally as well, PTs are, in essence, primary care providers of musculoskeletal pain.
Yeah. And we have an exciting opportunity that's coming down the pike. So historically, as you probably know, one of our challenges under MIPS reporting has been that we don't have any cost measures, and we have not been able to meet the certified health technology interoperability requirements. Right now, under the measures development wave 4 work group, there is the development of a low back pain cost measure. APTA is represented on that work group. I actually sit on that work group, as do two volunteer members. And what's exciting about this cost measure is that one of the triggering events could be a PT eval code. So it will be the first cost measure that a PT could actually trigger the episode. So that's really exciting. It's the first opportunity we'll have for that. We're hopeful that this cost measure may be available in 2023. It's going through field testing starting in January of 2021. It's PTs won't be the only triggering event. So the episode could be triggered by either an E&M code, so a physician visit, a PT eval, an OT eval, or a chiropractic procedure code. And the reason it's a procedure code for chiropractic is they bill E&M codes, but Medicare doesn't recognize the code. So we'd have to use a procedure code. But this will be the first opportunity to really look at a condition, low back pain, and see the difference in cost between an event that's triggered by a PT versus a primary care physician versus a chiropractor.
We have some of that data already, though.
We have some of that data. So we have it in the United Healthcare study, and TRICARE has some of that data, but this would be a very large scale under MIPS or MVPs, larger population. The challenge we had with UHC, even though the data is clearly convincing and indisputable, is that the N is relatively small for the number of patients that saw a PT first.
Mm-hmm.
So the more kind of measure, and even though we have the data from UHC, it really wasn't done as a formal cost measure for an episode model. So they went back retrospectively and looked at historical data. This would be kind of perspective, going forward, what is happening with these patients.
And this is all driven by CMS, Center for Medicaid Services.
This is all driven.
Right.
That's
so
right.
we're not necessarily talking about private insurance.
No, but it would give a framework that private insurers could also work under. So when you look at developing the cost measures, you look at how long is the episode going to be, what is the reasonable period of time from the triggering event to the first intervention, what's included and what's excluded, who are the primary populations and the subpopulations, how do you differentiate? That kind of data we didn't necessarily get in UHC, kind of all that drill down detail. So the opportunity to kind of define that up front gives us an interesting opportunity.
Personally, it excites me because I've always, as many of our peers can attest to, the CPT system is just so old and antiquated at this point.
Yes.
I think we have run it into the ground, and it's done. I really think it's done. The time has come for something like this. And I've always felt like, give me a lump sum of money.
Yep.
Allow me to manage it. And I can make a decision as a licensed healthcare provider, how many visits they need, how much time they need. The other thing, which I think people are also going to ask questions about, is, are they going to, so for example, if I am the trigger as a PT for that chronic low back pain and whatever, they give me $1,800, let's say. So now it's up to me to decide how many visits, how much time I want to spend with the patient, how much time the patient needs to have a positive impact. Are they also going to, and you alluded to this a little bit before, are they also going to track, are you doing Therex? Are you doing pain education? Are you doing CBT? Are you doing nutrition? There's so many, we are integrative professionals at this point.
Mm-hmm. Mm-hmm. Yes.
And with that, we don't quite have a CPT system that supports that. Might this be a better solution?
Yes, it might. And in terms of what's going to be tracked, that's kind of still to be determined. This is another one of those challenges in that transition to value-based care, is we have, cost measures over here, and we have quality measures over here, and we have improvement activities over here. And how do we pull those all together? Because you could have different providers using the same cost measure, but different quality measures, right? So the whole goal of MVPs, which is kind of the next generation of MIPS, is to get this all bundled together so that it is a composite of, specific quality measures and cost measures and improvement activities, so that we're really comparing apples to apples. And that's, that's the goal. We're not there yet. Once we get there, you could say that your quality measures and your improvement activities in some ways replace your CPT code, right? Because they become the description of what it is you did and how you produced this outcome at this cost. But it's an evolution right now. And, the reality is that the CPT system is so, kind of baked into our existing model. And there's a lot of stakeholders who have, desires and motivations to continue to have that structure. And it's not that it serves absolutely no purpose. It serves a purpose. So we have to figure out what of that plays a role moving forward, and how do you kind of transform that system in a way that it's meaningful? Because you're right, it's a little less meaningful right now.
Yeah. And my current position, and if you want to add to this or have anything to add to it, is I tell PT specifically, we have this idea as professionals that we have PT CPT codes, which we don't. They're just CPT codes that anyone can use. A physician can use our codes. They're not our codes. A physician can use what we would identify as traditional PT codes, right?
Correct.
So could an OT. Really,
Correct.
Any licensed provider could. And with that, we can bill other CPT codes as well. You may not necessarily get reimbursed for it, and you may have to do a little bit of work to get reimbursed for something that's not traditional, like nutrition, let's say.
Yeah.
But it's not outside the realm of what's happening, because it is happening.
Correct. Yeah, I think it's really important that physical therapists recognize that the CPT manual is a very large manual and describes a lot of procedures and services that are not specific to certain disciplines. They're placed in certain sections of the manual because it's more likely to be used by a certain group or specific provider. And there are some restrictions inherent in the specific code, a specific code that may limit its use. But, and things like practice acts may limit the use of certain codes, or payer policy, but it's not specific most of the time. And we really need to explore more, because our charge as any provider is to select the code that most closely represents the care that we're providing, not to try to retrofit our care into some short list of codes that we're used to billing. And so I do encourage people to kind of expand their working knowledge of the codes that are available. And we try through APTA to encourage people to kind of think outside that 97,000 series set of codes. Yeah. And also to work with your stakeholders, whether it be payers or employers, and talk about why using these procedures may be appropriate, and what you can demonstrate in terms of the effectiveness of those procedures when provided by a physical therapist, and try to push the envelope a little bit. Unless we push, our boundaries just get tighter and tighter, right? Everybody's just trying to restrict. We have to be looking to expand.
Yeah. Well, everyone listening to this podcast is pushing the boundaries. And I always recommend the two codes I encourage, particularly the people who follow this podcast, to explore: behavioral health codes, because they fit well with pain education, with mindfulness, with CBT-based techniques. And those are not codes that are only for mental health providers. We as PTs are making significant behavioral change, and there's time involved in that. And the other is nutrition, which is now part of our scope. And so again, I appreciate you saying push outside the boundaries. The one challenge, and this is for the people listening, the one challenge I find what happens is a PT will conduct a traditional PT evaluation, which is typically just strength, range of motion, function, things like that. And then like 4 weeks down the line, they'll throw in a behavioral health code, or they'll throw in a nutrition code and it gets denied. And they say, oh, this is not reimbursable. And I always say, well, go back to your evaluation, look at your evaluation. Did you have some kind of self-report measure that's related to either nutrition or behavioral health? Those are out there, readily available and easy to use. And did you include that in the plan of care? And if you didn't include it in the plan of care and you didn't do it in your evaluation, then of course they're going to throw it back to you and deny it. So we have a little bit of, and it's not difficult. We just have to be thoughtful at the time of the initial assessment to set up the person reimbursing the care, as well as the patient, to know that, hey, we may not talk about this on the first session, but we're going to be discussing many different components of your care.
Yeah, absolutely. And it goes back to that whole concept of whole person care, right? Really looking at everything that's contributing to the reason that that individual ended up on our doorstep, and everything that we have the potential to influence based on our knowledge base, our skill set, and our scope of practice. And really being as comprehensive as we can in that initial examination of the patient, using all of the tests, measures, patient-reported outcomes, patient interview techniques that are going to get us to the root of what we can and should be addressing. And at the same time, understanding that payer policy may constrain the use of some things, and we may have to fight a little harder and do some additional advocacy, or look at our specific contract with a payer that may be unique based on the types of services we provide as compared to other providers. But yeah, the onus is on the provider, right, to really define and defend what it is they're offering in terms of the scope of care that they can provide to a patient.
So as a healthcare professional who is interested in providing, effective, as you mentioned, whole person biopsychosocial pain care, as well as biopsychosocial, really any care at this point, everything should be biopsychosocial. Should we be excited about values-based care supporting that endeavor, and will it help with, I guess, more effective care going forward for chronic pain specifically?
I think the answer is yes, if we achieve the objectives that we're intending to achieve in this transition. So the goal really is to get to a place where providers are more focused on the broad needs of an individual, recognizing the importance of prevention, recognizing the importance of patient engagement in their own self-management, and really understanding what is the kind of quickest, least resistive path to the best end for that individual. So yes, it should take us there. We still have a lot of obstacles to overcome, and a lot of areas within the existing system that need to be challenged to get there. But I do think there's a great opportunity. I think we hit a little bit of a roadblock with COVID, and I don't mean COVID's little. I mean, it has thrown a roadblock in this transition, right? For a lot of reasons, delayed care, inability to access care. We've taken, in some cases, 12 steps backwards on some advances that we were making. People are, just trying to regain their footing from everything that happened. So we're going to have to kind of get the train back on the track again. But yeah, I think if we keep focused on the fact that our goal is patient-provider flexibility, whole person care, practicing at the top of our license, offering the full scope of what it is we can do. But we're going to have data, right? We have to have data. We've got to be gathering meaningful information at that first interaction with the patient. We've got to be able to capture it at points across the episode of care, measure the impact at the end of care, be able to speak to what it took to get there, understand the cost of the care we provide. All of those things are really important.
Lots of different topics. As you mentioned, COVID brings in a different flavor, which we weren't anticipating. So it impacts all our efforts, I would say.
Yes.
And like many things, there's some silver linings, like telehealth came out of that,
Yes.
which has been important. Alice, obviously you work within the APTA, and we thank you for your service to, the association and to our profession. You mentioned the word barrier.
Mhm.
And I'm just curious, just not just from a values-based perspective, but just kind of from where you're sitting and your experience both as a clinician, and you've done some research and now you're working more, from with inside the association. What do you think is the one biggest barrier that we have as physical therapists for moving our profession forward to where we should be as a licensed doctoral leading health profession in the United States?
That's a really good question. Um, to up with a single barrier is difficult. I think certainly one of the most significant barriers is kind of where we're positioned in the healthcare system. In that, in most settings and in most models, we are not kind of that first line of defense, that front line point of access, which is so important for many conditions because there's windows of opportunity with patients to really impact downstream cost, impact meaningful outcomes. And so when patients don't get to us till 2 weeks or 3 weeks or 4 weeks or 5 weeks in the course of their condition, that delay is often insurmountable
So when you
in
say
terms of, I'm
when
sorry.
you say our position, I just want to clarify because there's lots of different ways to define that. But I think what you mean on some level, and correct me if I'm um, quoting you wrong, we're in some way still looked at as allied health providers where we really need to be in that primary care. I don't want to say primary care. Primary care is primary care is
Right.
different. It is.
Right.
I've learned that primary care is different, but really
Yes.
primary health provider role.
Yeah. Correct. I think it's kind of point of contact. If you think, can we be a first point of contact? So yes, I think primary healthcare provider is probably a good term. And we're constrained by a number of different things, whether it be payer policy, Medicare regulations, state regulations, simply consumer awareness. There's a lot of things that create that barrier. So we have to take all those things on. And I'll tell you, probably one of the big things is that whole consumer awareness piece, which is why Choose PT has become such a broader consumer awareness campaign to really let people know that we're here and you can access us first. Because there are a lot of situations under which patients can access us first, and they're not fully being leveraged yet. So that's one thing. I would say the second barrier is sometimes one of our own making, in terms of making sure that as providers, we are embracing evidence-based practice, that we are current on effective interventions, that we're really, for low back pain, for example, looking at things like active versus passive interventions and how important that is. And so, although there's some argument to be made that variability in practice is not as important, because when you looked at the data like from UHC, we don't know what, other than the difference between active and passive, we really don't know what treatments those patients receive specifically, but we know no matter what, if they saw a PT first, the cost was lower. So, at that highest level, you could say it kind of doesn't matter as long as they see a PT first, but it really does matter when you
Yeah.
start to drill down.
Yeah.
And so if the numbers were larger and we could kind of compare intervention to intervention, I think we as a profession just have to make sure that we are doing what we need to do to be as current as possible and that we're gathering meaningful data. We're still not there with every PT really gathering useful data. I mean, you talked about it in the beginning. What's an evaluation? What really falls into an examination? If you look at the guide to PT practice, it's a lot more than range of motion, strength, and function, right?
Yeah.
We need to look at really the full depth and breadth of what we need to be gathering. And then we need to extrapolate out from all that data what's most meaningful. and what we really need to drill down and measure around, and then make sure that we're not just doing it at the start of care, but throughout care and at the end of care. And that we're considering patient-reported measures, because that's really important as well.
Yeah.
We may say, oh, look, how wonderful we did. They're doing all these things better. But if at the end of the day, the patient isn't where they intended to get, and we haven't gotten to a place where we fully understood their expectations and are able to deliver on them, that's a real problem. And I say the patient, that could be the employer as the stakeholder. It could be the payer as the stakeholder. So,
well, there are definitely opportunities here for PTs to start to look at what's happening, to follow what's happening, right? Within this whole concept, both on the CMS level and then private payers, because some private payers have started to dip their toe into this area. And I think it's a place where PTs can start to step up and say, hey, I can be the one to manage this, especially within the realm of certain lifestyle related chronic pain conditions, which are so prevalent both in the private sector as well as the public sector. So I think, you did an excellent job of really kind of drilling down to some of the details about this today. And hopefully people are interested in watching this unfold and become involved in all the different ways we can become involved to support this. I do think values-based care will continue, and it's important, especially in the world of pain care. If people want to continue to follow this topic and the work you're doing supporting this topic, how can they do that, Alice?
well, please first go to the APTA website and really get engaged with all of the information and the resources that are available to you. Also, if you have questions or issues or concerns, you can email us at apta@advocacy.com. And someone from the APTA team will get back to you and support you in those efforts. Be an engaged member, get involved, look at the opportunities for advocacy, and please take part in them. The more voices, the better our opportunities are for positive change. Also get involved at a local level. Look at places where PT can be represented on local work groups or boards or communities. We saw that a lot with the opioid epidemic, that there were a lot of these local councils developed, and PTs who sought to get involved were able to be on these councils and really influence the direction, particularly in Medicaid programs and other state-based programs, of where funding would go and what would be considered. So just be engaged, be involved, and please avail yourself of the resources that APTA has put together.
Great. So of course, everyone knows the website. It's apta.org. And I just want to repeat that email one more time, Alice. So if people wanted to email, let's say that email one more time for us.
Sure. It's advocacy@apta.org.
Okay. So advocacy@apta.org. Of course, we'll link to that, the URL for the website, as well as you can find that on the show notes at the Integrative Pain Science Institute. So if you want to reach out to Alice or other members of the American Physical Therapy Association and see how you can become involved or gather some more data on this important topic of value-based care, that's there for you. I want to thank Alice and everyone at the APTA for helping support this mission and for joining us today to discuss this topic. Make sure to share this with, of course, your colleagues in the PT profession around the globe. I think this is an important global issue, but other colleagues and friends and family might be interested as well, because these do have overlays with political issues that all of us are interested in with effective and affordable healthcare. So make sure to share this with your friends and family on Facebook, LinkedIn, Twitter, Instagram, wherever anyone is talking about values-based care. Take a screenshot of today's episode on your phone and tag me at Dr. Joe Tatta on Instagram, and I'll be sure to tag you back. Once again, I want to thank Alice for being here. I'm Dr. Joe Tatta, and we'll see you next week.
Thanks so much, Joe.
Thank you for listening to the Healing Pain Podcast with Dr. Joe Tatta. To subscribe to the podcast and learn more, visit integrativepainscienceinstitute.com. That's Integrative Pain Science Institute.com. Sign up to receive weekly updates, leave a review on iTunes, and share this episode with your friends.